haven't got any sound. It's probably because it hasn't started yet.
Well, is your mic on?
Yeah, it's all right, it's on mute.
Oh, that's it.
Good afternoon, Chairman.
Good afternoon, everyone, and welcome to this virtual meeting of the Lincolnshire Health and Wellbeing Board. I'm Councillor Sue Woolley, and I'm the Chairman of the Board. Welcome to all members and officers in attendance today. The audio feed of this meeting is being broadcast via the County Council's website, and I would also like to welcome the members of the press and public who are listening to our meeting online today. Anyone invited to speak during today's meeting should unmute their microphone and switch on their camera. Please turn off your camera and microphone when not participating. If you wish to speak, please use the chat function and type speak or raise the hand. I don't mind which. I'd rather it was the symbol hand rather than your own hand like this, though. And we'll all be keeping a note out or look out for who's got hands raised, etc. The Senior Democratic Services Officer will indicate in the chat function when a new item has begun. It's my intention, wherever possible, that decisions will be reached by consensus in exceptional circumstances, and where decisions cannot be reached by consensus of opinion, voting will take place and decisions agreed by a simple majority. If you experience any IT issues during the meeting, please end the call using the red phone icon and rejoin the meeting using the link previously provided. If you continue to experience connectivity issues while speaking, please turn off your camera, as this may help. If you continue even then to experience IT issues, please contact Simon Firth, IT engineer, for assistance. Can I also ask that members who are intending to leave the meeting or are returning to the meeting indicate using the chat function? Officers don't need to do so. Can I now move on to ask Katrina Cope, Senior Democratic Services Officer, to confirm the presence of all members, officers and guests in attendance at this meeting. Thank you, Katrina.
Thank you, Chairman. Good afternoon, members. Could I please ask you to confirm your presence when your name is called? Councillor Patricia Bradwell.
Present.
Councillor Mrs Wendy Bokett.
Present.
Councillor Rob Kendrick.
Present.
Councillor Hugo Marfleet. Councillor Ron Oxby.
Present.
Councillor Mrs Sue Woolley.
Present.
Councillor Nick Worth.
Present.
Ben Garrod.
Present.
Linda Dennett.
Present.
Eric Ward.
Present.
Turner. John.
Present. Hi.
Hi. Councillor Donald Namstat.
Present.
Mark Jones.
Here.
Thank you. Mike Hill. Mike, he was here earlier.
He's on mute at the moment.
Right.
Present.
Thank you very much. Jason Harwin.
Good afternoon. Present.
Thank you. Can I just go back to see if Councillor Hugo Marfleet's in yet, please? He may come in later then, Chairman.
Okay.
We also have the following officers present here today. We have Alison Christie, Programme Manager, Strategy and Development, Public Health, Dr. Kakule Chowdhury, Public Health Consultant, Lorraine Graves, Interim Head of Mental Health Services. We have a guest, Sarah Connery, Acting Chief Executive of Lincolnshire Partnership NHS Foundation Trust, and observers, Janet Inman, Non-Executive Director, NHS Lincolnshire CCG, and Rob Gray, who's the Staff Officer to Deputy Chief Constable Jason Harwin. Thank you, Chairman.
Thank you, Katrina. Have we got anyone participating in the meeting today who's not had their name called by Katrina? I'll take the silence as a no. So then can we move on to apologies for absence, please, and replacement members? Katrina, do we have any apologies?
Thank you, Chairman. We've received apologies from Councillor Nigel Pepper, Heather Sandy, Executive Director of Children's Services, but we have Linda Dennett, Lead Nurse for Children's Services, replacing Heather today. And we've also had an apology from Elaine Bayliss, from the Lincolnshire Coordinating Board. Thank you, Chairman.
Thank you, Katrina. Okay, item 2, declaration of councillors' interests. If any member would like to declare an interest, can you please indicate in the chat function now by typing speak? No, I don't think there is. Okay. Alison, do we have any members who'd like to declare? Just double checking with you.
No, no one's indicated.
Okay, thank you. Agenda item 3, minutes of the meeting of the Lincolnshire Health and Wellbeing Board held on the 1st of December 2020. This item is to confirm and sign the minutes from the last meeting of the committee on the 1st of December 2020 as a correct record, pages 7 to 15 of the agenda pack. I'd like to propose the minutes are a correct record. Do I have a seconder?
I'll second, Madam Chairman. Ron Oxby here.
Thank you, Ron. Do we now need to, I assume we have to vote, Katrina, so can I just ask that any member who wishes to abstain, would you indicate in the chat function? And likewise, any member wishing to vote against, would you like to type in the chat function? Okay, rather than putting my arm over and you just seeing that, Alison, can you just tell me, has everybody indicated one way or the other, or in other words?
No one's raised their hand.
Okay, that's absolutely fine, thank you. So I'll take those as a true record. In the absence of any votes against, then I'm taking the minutes confirmed and signed as a correct record. Can we now move on to item 4, which are actions updates? And as you will see on pages 17 to 20, this item's for information only. Do you agree that the notes of the action updates are accurate? And again, could I just ask you, if you either disagree or wish to abstain, then would you put that in the chat function? Okay, Alison, is there anything there?
No one's indicated anything in the chat.
Okay, we move on to item 5 then. Oh, Councillor Bradwell, you will be getting to your walk early at this rate. Item 5, Chairman's announcements. And the report for this item is on pages 21 to 25 and is for information only, because I'm assuming that everybody's read it. Can I ask, however, I would just like to make a slight amendment to the Chairman's announcement and make an additional announcement. If I could just inform the board that I regret to tell you of the death of Michael Oliver, who was the Chairman of the Board of Trustees at Linkage and a member of Linkage for over 12 years. I understand he played a very valuable part and worked very closely with the County Council in the adult care arena. So our thoughts go to his family and friends. Thank you.
Yeah.
So can we therefore, are you happy to note the Chairman's announcements? Again, if you have any anything to say or abstain or against, can you just put it in the chat? Again, Alison, is there anything there?
No one's indicated anything in the chat.
Okay. We move on to our first decision item, or our only decision item, I think, fair to say, 6A. And this is changes to the Health and Wellbeing Board terms of reference to incorporate the functions of the Integrated Care System Partnership Board. John and I are going to give you a bit of a brief overview. It's going to be very brief from me, really only to say that this piece of work has been being done in the background and is on the back of the health and care white paper. The suggestions in there that the Integrated Care Partnership Board, which is going to come into existence, and indeed integrated care boards in general, in this next 12 months. John came forward with what I believe is a very, very good idea and sensible idea, that rather than us having the ICS NHS board, the ICS partnership board and the health and wellbeing board, that we looked particularly at the partnership board, whether we could, and these are my words, sort of morph the health and wellbeing board into the partnership board, or indeed the partnership board into the health and wellbeing board. In other words, let's not have 3 separate boards, because most of the people who sit on one will be sitting on the other. Let's look at if we can find a way of amalgamating potentially 2 of these boards, and this would be for the good of our residents as much as anything, and trying to streamline and make it as easy as possible to work across the different sectors. John, would you like to add anything to that?
Thank you, Sue, and afternoon again, everybody. Just a few brief comments, if I could, please. Clearly, the white paper is now out, integration and innovation, and there's a briefing note just further up the agenda in terms of the headlines for that. In broad terms, the white paper on health and integration is very much in line with what we've been how we've been developing, I think, in Lincolnshire. Arguably, it's a bit of a catch up with where we are, because Sue, we've been working well together across local government and the NHS for a number of years. I think we all feel we've advanced that joint work quite a lot more recently, and you and I were looking at how we could just support the further evolution of the Health and Wellbeing Board into the future in any way in that setting. What the white paper intends is that, subject to the passage of legislation through Parliament, there will be a statutory integrated care system in all the systems, of which Lincolnshire is one, and that statutory integrated care system will consist both of an NHS integrated care system body and a health and care sort of partnership board. That, I think, for us is very much what the Health and Wellbeing Board is in Lincolnshire, and I think that the revised proposed terms of reference will just help us to evolve forward in that way. So from my perspective, Sue and colleagues, I think this is a very sensible, straightforward way forward. It helps us to further work together, integrate things for the benefit of the people we serve, and it's also helping us to minimise bureaucracy and avoid duplication. So I'm very happy to put my name to it, Sue. Thank you very much. I'll pause there.
Thank you, John. And yes, we could go on about all the various bits and pieces of it, but I think if we just give everybody the opportunity to ask some questions, probably more information will come out through the questions. Councillor Nanstad, you have the first question.
Right, thank you. Can you hear me?
Yes, I can. Thank you.
Yes, it might not surprise you as to what I'm going to say, but I did notice that obviously there's several references in this document to partnership working and that sort of thing, and district councils, certainly during the pandemic and before, have been heavily involved in this area, and the district councils do feel that to only have one representative is not sufficient, and that there should be at least 2. Other health and wellbeing boards and similar bodies do have a higher representation of districts, and to be fair, it has to be said that districts have done a lot of work in this pandemic, and there's been a lot of collaboration, and they feel a little bit let down that there is a recommendation on that particular section of membership is only for one. So just make that point. Thank you.
Thank you, Councillor Nanstead, and I think you make a very fair point as well. You're quite right that the district councils have played a huge part in the COVID pandemic. What I would say, as far as this membership is concerned, there is no way that in 12 months' time, as the ICS gains a statutory footing, that I believe the membership will be the same as it's being proposed at the moment, even for the very simple reason that the CCGs, there's a proposal that they will be discontinued, so that there will be a change there. And I think probably that come October, November time, we will be re-looking at this membership anyway, because of what comes out later in the year as far as various policies are concerned. But this is very much a starting point, because we have until April 22 before the legislation actually comes in, and this just gives us the opportunity to work through some of those sorts of points and whether we've got the right membership. So I do hear what you're saying, and I do think it needs to be taken into account before the ICS Partnership Board becomes on a statutory footing. John?
I think Tricia was in before me, Sue.
Oh, was she? Well, only just. Right, okay, Trish.
I'll defer if I have to.
No,
I'll defer. Only joking. No, I was just going to say, because, I mean, we have taken, the first steps, and I think those have been able to be made because of, the partnership working that we do have. I mean, there is much more joint working we need to do. There's no doubt about that, but we are on a good trajectory, I think. And as has just been said, we don't know what government are going to tell us that we have to do in making these ICS committees. So I think at the moment it's good that we've taken this step, and that we're here around the table today. But I think we do need to probably just wait now and see what comes out of the legislation that will go through Parliament eventually. But I don't think that stops us from doing all the good joint work together. And as Councillor Nanstead said, that during the pandemic, I think we've all worked very closely together, and that's even the voluntary sector and everybody pulled together for the people of Lincolnshire. It's absolutely amazing. So I think we are on the right journey, but at the moment we're not there, and we have to wait for the legislation that goes through.
Thank you, John.
Yeah, I think it is a point very well made, and I must say that from my perspective, the district councils, individually and collectively, have been great partners with the health service and obviously the county council as well through the course of the last year. Gosh, is it only a year through the pandemic? And it's not just the pandemic; it's things like the towns funds as well, isn't it? There's been a lot of joint working gone on behind that. I actually meet with the district council chief executives on a weekly basis at the moment, and I know that they are looking to explore how the partnership and the integration with their partners under the sort of the broad integrated care system umbrella, how that should be progressed. So it might be helpful to see how that work evolves going forward. A bit like Councillor Bradwell said, I think we've come a long way together, and I think we're on a great trajectory of continued joint work and in partnership with the district council colleagues, as well as all of our other partners in the county. Thank you, Sue.
Thank you, John. And if I could just add to that and provide some reassurance, as Councillor Boquet has pointed out in the chat, there are a number of us that are also twin hatters. And I note that Mark Jones says, well, you've got to be one or the other here. But I sort of slightly disagree in as much as I certainly take back all of the information from this Health and Wellbeing Board to the district council that I sit on. So effectively, the district, for me, the district council has got, well, I think it's 4 because Councillor Oxby is a district councillor as well. So they've got 4 representatives that are around this particular board. But I think if we work on the basis of being fairly pragmatic at the moment and then seeing where we are in roughly 6 months' time or so and what more information is coming out, and then we can make changes as we go along. Okay. Thank you, Councillor Oxby. He's just corrected me. He's not a district councillor anymore. I do beg your pardon, but you were once. Okay. Is there anybody else that would like to make a comment at all? Okay, well, in that case, I'd like to take us to the actions required, and that's on page 27 of the report pack, and that's to endorse the revised terms of reference set out in Appendix A, and then 2, to recommend the changes to full council to enable the necessary changes to be made in the council's constitution. And again, if I could just very briefly point out to anybody who might not understand, this committee is technically a committee of the county council, so it has to go through full council if there are any changes made. That is the only reason. So that's just keeping things in order. So I move that we support these recommendations. Can I have a seconder, please?
I'll second that.
Thank you, Councillor Bradwell. Moving to the vote, would anybody like to abstain or vote against? If you would like to indicate in the chat function. Okay. And then, Alison, are there any indications in the chat function?
Councillor Landstat has voted against.
Okay, that's fine. And so, as far as I'm concerned, then the rest, I assume that everybody else is for, by not putting anything down, if that makes sense. So therefore, this is carried.
Would you like a roll call to be taken so that members of the public know how people vote, Councillor Woolley?
Well, I'm not sure it's really necessary, because if against and abstain hasn't been put in the chat function, then by the very nature, everybody else must be for it.
Yeah, fine, thank you.
I'm happy to be guided by colleagues if you feel very strongly one way or the other.
No.
Right. Okay. We will now move on then to item 7A, which is the COVID-19 update, and ask Derek Ward, Director of Public Health, to provide an update on the current COVID-19 position in Lincolnshire. Thank you, Derek.
Thank you, Councillor Woolley. Good afternoon, everybody. So the current position, I'll do what's in the public domain first, and then I'll give you an update on our more up-to-date data that we keep a track of. So in the public domain on the government website, the England rate, just by way of context for COVID, is 66 per 100,000 population. And on the government website, the Lincolnshire rate is 79.9, so just under 80. On our local data, which we are expecting to be updated later on today, our rate has actually come down to 70 per 100,000. So we're not far off the England rate on our data, and that's for the 7 days up until the 6th of March. Some nuances within those rates. A big county like ours, you would always expect when we're looking at a Lincolnshire level, it will average out some of the differences, and indeed that's what we're seeing at the moment. We have East Lindsey with North Kesteven with rates of around 40 per 100,000 at the moment. And at the other end of the scale, we've got South Holland and Boston. South Holland's about 137th, 138 per 100,000, and Boston's 114. I would say that once we go below Lincolnshire level, even when we look at a 7-day rolling average, it doesn't take much for the figures to jump around, because if we get an outbreak in a factory setting, or we're still seeing some small outbreaks in care homes because of the time it takes for a full antibody response to come in, then the figures will jump around. So, for example, that rate of in Boston of 114 per 100,000 is based on 80 positive cases over a 7-day period. So we're not talking about large numbers overall. But generally, downward travel, although we are bottoming out, and it's a slow descent now, which I think is replicated by the national picture. Clearly too early to understand what the impact of schools going back is at this point. I would expect to start to see any impact of that towards the middle and end of next week, given the time delay that we would expect with the natural history of this disease. So certainly for the next Health and Wellbeing Board, and we have weekly strategic coordination groups meetings that will look at this. We'll start to pay very close attention to those data next week and see if we see any impact. But as of this point, our rate in school-age children is very low. It's less than 40 per 100,000, so around a half of what the overall rate in Lincolnshire is. And the rate in our over 60s is around 35 per 100,000. So what that tells us is the majority of cases that we're seeing are in working age adults in Lincolnshire. Again, that's not an unusual pattern. We're seeing that across the country. I think in terms of the numbers, that's all I'll say. We are carrying out lots of tests. Nearly 70,000 tests were carried out in Lincolnshire over the 7 days up to the 6th, which is great, because the more we test, the more we're likely to find the disease and make sure we can stop people passing it on. And on that, we have a number of different sites now open where staff and citizens can go and get a test even if they're not got symptoms, so asymptomatic testing using lateral flow tests. Final thing I'll say on that is we've carried out up to this point more than 25,000 tests using lateral flow tests across the county, and we've found just under 350 positives, giving us a positivity rate of about 1.3, 1.4%. Clearly not huge numbers, but every one of those people who test positive is somebody who didn't know they had it because they've got no symptoms. So certainly helpful to take those people and explain to them that they have the disease so they can isolate. I think that's probably it in terms of COVID. Happy to answer any questions any member may have.
Thank you, Derek. John.
Thank you, Sue. And just to build on Derek's excellent update to the board, and Derek, just to say thanks again to you and your team for the brilliant work and support you're giving on this. I thought it'd be helpful just to say give a few figures about where we are with the vaccination programme.
You can do, or do you want to leave it until we move down into, I thought there was another section somewhere. Alison, help me out, because we were trying to preempt you.
No, this is
no,
where
it is this one. It is this one. Yeah. Yes, please, John, we would like you to say something.
I'm always happy to be preempted. That's not a problem. The headlines are, we've got just about 650,000 people aged over 18 in the county who'll be offered a vaccine. We're at about 300,000 people having had their first vaccine now. So really good progress being made. You'll be aware that we've been working our way through the priority cohorts. So priority cohort 5, which is 65 to 69-year-olds. We've done about 90% of those people across the county. Cohort 6, which is people who are clinically at risk, we're about 60% of the way through that population, just over 100,000 in Lincolnshire. A week before last, we opened up the 60 to 64 year old cohort at 7, and just at the weekend there, the cohort 8, the 55 to 59-year-olds. All of our services are up and running, as they have been for a little while now, and I'm really delighted with the progress we're making. Lincolnshire's vaccination numbers are more than holding their own by comparison to other systems in the region. We've started this week the second doses for people who got their first in the middle of December there. And over the course of the next couple of weeks, we're anticipating a significant increase in vaccine supplies available for both the country and indeed in the county. So at the moment, whilst there is a long way to go with the whole vaccination programme, we are currently on course to meet the government's target of everybody over 50 having received or been offered their first vaccination by the 15th of April, so that's just over a month's time, isn't it? And then obviously there's the subsequent target of the whole adult population having been given the opportunity to have vaccine by the 31st of July. So hopefully that's a helpful update. So thanks very much.
Thank you. Councillor Nanstead.
Thank you. Thank John and Derek for their reports. Obviously, the figures fluctuate almost daily in terms of how many cases there are, and it's actually quite difficult sometimes to give a definite figure. Can I just check that there's a 7-day summary which is issued daily? Now, is that accessible to all districts? I mean, I see it, but I don't know if the other districts see it, judging by some of the questions they ask me. So that's a simple question. Secondly, do we know how many people who have been eligible so far have refused or have not taken up the offer of being vaccinated, and whether there's been any sort of analysis of who those people might be? And thirdly, this is a question I asked in another way previously to Derek, which was the longer term effect of COVID. And certainly there's certainly some evidence of increasing levels of depression, anxiety, loneliness. And the last time I asked, I was told that there was no plans at that time for extra funding for mental health services. And the implication of increases in those sort of conditions suggests that perhaps there should be, because otherwise, if the service could find itself in difficulty in terms of the number of people coming forward wanting help and the number of people that can actually be helped. In connection with that, I mean, generally, do we know what the long-term impact is looking like? I mean, maybe even now it may not be possible to give a particularly clear answer on that, but it would be useful to know. I think that's all the questions I've been asked to put forward.
Derek, you want to kick off, and then John, will you join in?
Yeah, thanks, Councillor Woolley. Thanks, Councillor Hampstead. In terms of the short answer to have all districts got access to the data, I've just given you yes.
Yeah,
there are officers in every district who have access to. It's on a restricted SharePoint site, yeah, and we update it daily directly from the detailed positives we get at an individual level. So yeah, they have access. In terms of the wider question, and I'll pass over to John to talk about those people who haven't taken up the vaccine. I think Sarah's already said she can cover some of this in her presentation in terms of mental health services in Lincolnshire. We are looking at what will come from the Department of Health and Social Care. We are looking at what the implications down the NHS line are, and again, John may want to mention something about that. We're also looking at what the rules are around the current funding we've had from central government that has been focused predominantly on the response, the immediate response to COVID, and whether we can use any of that funding for response, but also early stage recovery. So we're certainly looking at the existing funding streams we've got to see whether they can be used, but they come with stipulations about what you can and can't do with them. In terms of the wider work, we're working with Sarah and her team, I'm sure she'll cover, about recovery and what we need to offer, by the way, across the mental health spectrum, including mental well-being, social isolation, loneliness, and that whole side of it. And then any funding coming down the NHS side, I'll leave to Sarah and John to pick up.
Thank you, John. Is there anything you want to add to that?
Thank you, Sue. Yeah, the first question about people who have not taken up the offer. Yes, clearly we do know who we've offered it to, but having not taken it up can have a number of elements to it. So one element, for example, would be people who have actively refused to have it, which is a very small number of people in Lincolnshire. I mean, the headline is we have very high uptake in Lincolnshire and very high uptake actually across the country. The people who have actively refused to have it is very, very small indeed. There are also a number of people who may not have been able to take up the offer, but will be able to in time. The most significant group is probably people who actually are COVID positive. You might be aware that if you are COVID positive, you need to be clear for, I think it's 28 days before you can then have your vaccine. And then there are those who have had an offer of vaccine, but for a number of reasons require a bit of further follow-up from the NHS. And the teams across the county are doing exactly that. And again, we've broken down the take up in the population using the what's it called, the index of multiple deprivation to assess which communities across the county have taken it up by comparison to others. And I don't think you'd be surprised to learn that the more deprived communities in Lincolnshire have a slightly lower uptake than the less deprived communities. And as a result of that, we've actually got a team, specialist team within the vaccination team, which is particularly focused on trying to make sure that we get to everyone proactively. And clearly there are communities such as homeless people, for example, who we need to make sure we've got a bespoke offer in, because we can't leave anyone behind on this one. Interestingly, and again you'll see it on the national media, there are concerns in some parts of the communities across the county and the country, particularly people from a Black, Asian, minority ethnic background in terms of uptake. But again, that's an issue we are focused on in Lincolnshire, but clearly other parts of the Midlands region, that's a more significant issue that they are looking to address and have bespoke arrangements in place to do just that. So hopefully that answers the question on the take up. As we get through the population groups, we anticipate that there might be issues, for example, younger women, because we know that there are concerns about fertility, for example, which are again have been well reported. But the big message is this is going really well, and the uptake is very high in the county. I know that Sarah Connery will pick up the issue about mental health and long COVID, and some really, I think, quite impressive work that LPFT with partners are doing to try to address actually the totality of the mental health impact of this whole pandemic on the people we serve. But just to really build on Derek's comments, that there's a lot of complexity around this condition along COVID. It has quite a number of impacts on people in different ways, and our clinical leads are doing a lot of work on this at the moment. Clearly, for some people, there is a mental health impact, but there are other quite significant and different physical health impacts as well. And as you indicated, we're still learning a lot about this condition. But please be assured that this is being actively looked at by our clinical leaders. Thank you, Sue.
Thank you, John. Councillor Oxby.
Thank you, Madam Chairman. John did just mention about people just beginning to have their second injections. Something I've been thinking about for a few weeks now. I was up at the showground having my first one a few weeks ago, and I must admit, everybody I've spoken to has said how absolutely fantastic it was, so efficient that you've had nothing but praise. So you've got some brownie points there for a lot of the population. But what I was thinking was, once we start injecting people for the second time, it surely is going to slow up the process of those receiving the first injection. For argument's sake, if we're doing 1,000 people a day, once we start injecting the second doses for people, theoretically, if say 500 are going to have the second dose, the first dose is going to be reduced by 500. So I would just wonder if this has been taken into consideration into all the equations that the government and presumably yourself have taken into consideration.
John, do you want to take that one?
Thank you, sir. Thanks, Ron. Firstly, thanks for the brilliant feedback. I'm glad it went well for you. Thanks for sharing that with me. Yes, there is a huge amount of very, very detailed planning that sits behind all of this, and of course you'll probably be aware that we're working with two vaccines at the moment, Pfizer and the AstraZeneca Oxford one, and whatever you had first time round, you've got to have it for your second dose. So at the moment, people are getting their second doses. They had Pfizer in December. You may recall that the AstraZeneca wasn't even approved by MHRA until I think it was just before New Year, wasn't it? So all of this is scheduled. There are very detailed schedules going forward. As I'm sure you're aware, people are you get booked in for your second jab as you book in for your first. So all of that, planning is being done behind the scenes. And just going back to something I said in my opening comments, that the supply of AstraZeneca is going to significantly ramp up in the coming weeks and stay at a sustained high level, certainly to well into May. So that's what gives us confidence that we'll be able to run, if you like, the parallel streams of the second jab as well as the first. It is all dependent on the supply coming in. We actually have good capacity in terms of the number of sites we've got and the workforce availability. So that's why I can say we're confident with what we know at the moment, and if the supply comes through, that we'll be able to meet that government target of the 15th of April.
Good. Thanks very much.
Thank you both. Okay, If there are no more speakers, I would just ask the board to note the COVID-19 position from both Derek and John. Thank you. We will now move on to item 7B, which is Derek's Director of Public Health Annual Report 2020. For one or two reasons, Derek, it's probably not, it's been around a bit, hasn't it?
It has indeed, Councillor Woolley, thank you. And I'm not proposing to spend a lot of time on this. I remember when we brought the 2019 DPH report, we had a really good conversation, and I was hoping that the 2020 report would be an expansion of that, looking specifically at children and young people. But unfortunately, understandably, with COVID, we thought it was more useful to provide an overview for the people of Lincolnshire about the response that we've mounted to deal with COVID-19, and that's what the Director of Public Health report outlines. It's broken up really into four key areas, and it comes back to previous conversations actually. One really was, what has the impact of COVID-19 been across Lincolnshire, and that's the section after the introduction. Clearly, the minute we finished writing this report, the data gets updated, so it's moved on since then. But as of the time that it was written, it gives an overview of all of the challenges that we faced as a county and the fantastic work we've all done together collectively as a county to deal with COVID. And that leads into the second section, which was how we've worked across the system as multiple agencies. I remember the very first conversation we had about COVID-19, myself and the Deputy Chief Constable who was on the call, was the last day of January 2020, so well over a year ago. And that section describes the process that we've been through and the multi-agency response that we've mounted to deal with COVID-19. We've talked a little bit about future planning and response, which is always quite difficult to do, especially when we wrote this report, because it was before we had the government's roadmap out of lockdown. But we've outlined what the plan is, or what the plan was at that point. And just for everybody on the board's awareness, we have our local outbreak management plan, which is published on the council's website, which outlines how we're going to work on this. And we are just updating that in light of the government's roadmap, and that update will be published in the next couple of weeks as well. And then we touch on some of the longer term implications of COVID-19 in terms of health and wellbeing, which is previous conversations that we've talked about before. So I don't know whether anybody else can see, but I've got a strange screen in front of me where it's you're back, Councillor Woolley. So that's the overview. I won't go into the detail because there's a lot in there, and obviously it has been updated since. I think probably that gives an overview, and I'm very happy to answer any specific questions members of the board may have.
Okay, thank you for that, Derek. Are there any questions from anyone? I can't see any. You're going to get away with this very likely. Yep. Okay, let's move to the actions required. The Health and Wellbeing Board is asked to, as per page 43 of the report pack, receive the Director of Public Health's annual report and to note its content. Is everybody happy with that? If you are not, would you like to either abstain or put against in the chat function? Okay, I will take that as agreed. Thank you. Thank you, Derek. Can we now move on to item 7C, which is the Integrated Care System Update? And I'm going to invite John Turner, Chief Executive of NHS Lincolnshire Clinical Commissioning Group, to update the board on the progress made on the Integrated Care System in Lincolnshire. Over to you, John.
Thank you, Sue. I'll take the paper as read. Really, as we were saying earlier in the meeting, I think we've made a lot of really good progress the past few years together. between the NHS and local government in terms of joint integrated working. I think there's a huge amount that we can point to in terms of how we all just try to work together in partnership and collaboration for the overall benefit of the people of Lincolnshire. In January 2019, the NHS England issued its 5-year long-term plan, and that included a requirement for all parts of the country to become what was called an integrated care system by April 21. And we have, over the past few months, been in a process of discussion with NHS England about our working arrangements to become an integrated care system by April 21. In many ways, it's just describing all of the good joint working we already have in place, because we've developed and evolved it together, and all of the excellent work that we already have in place, because we've developed it and evolved it together. So in a sense, there is very little that is new in the requirement to become an integrated care system for April 21. And that submission actually was made by myself and Debbie Barnes with the support of our colleagues, not just in the County Council Executive and the NHS Trusts, but also our colleagues in Lincolnshire and the third sector, the voluntary engagement team in the county, representing that sort of wider partnership collaboration. Because we all know that whilst local government and NHS working together is vitally important, it's not just about these two working together. We need to work with a wide range of partners across the county, and that's exactly what we do. So at the moment, we are awaiting a signal from NHS England, London headquarters, in terms of whether we will or will not be designated as an integrated care system for 1st of April. Just coming, all of the mood music is very encouraging and positive in relation to that, but we are yet to formally hear. I think what we can now see is that becoming an integrated care system for 1st of April is really going to be a stepping stone towards becoming a statutory integrated care system in line with the white paper requirements from the 1st of April 22. Again, Sue and colleagues, I think we'll just continue to evolve and develop that together. And whilst during the course of the rest of this calendar year, we'll be planning that statutory ICS. And within that, clearly the CCG come 31st of March 22 will cease to be a statutory organisation, and its responsibilities will move into the NHS ICS body. I think the general sense I have is that we're very much on the right tracks. We've got a lot already in terms of how we are working and what we're delivering, that just shows how strong our partnership and integrated working is in the county. We'll continue in that fashion going forward over the next 12 months and into the statutory arrangements, if indeed they get passage of legislation through Parliament in time. I'll pause there, Sue.
Okay, thank you. Okay, questions. Jason.
Thank you, Councillor Woolley. John, I suppose my first question is in terms of the learning from COVID, and obviously that bit where we've had to come together, quite rightly come together and make the difference we've been talking about so far. Do you think there might be any pausing moment just to get any learning from COVID? Because obviously there is some opportunities from the COVID response that would obviously fit very nicely into this agenda as well. So I don't know if you get a flavour of that, or whether it be a case of just keep going in the sense of direction we are now.
I think it's both of those, Jason. It's a really good point that you make. Certainly within the NHS world, I don't get any sense that we will have much downtime in the year ahead to properly sort of reflect on everything that we have learned as a sort of exercise in itself. Because very soon we will be being asked to press on with catching up on elective surgery, cancer care, diagnostic services, and all of the rest of it. So what we have tried to do is to try to build the learning and reflection in as we've gone along, and we will be conducting a similar bit of work in parallel, I anticipate, probably over the first quarter of the new financial year, as we do so, and obviously yourselves will be very welcome to be part of that. But I think that for me, the headline message from how everybody has worked together in Lincolnshire is that we just intuitively know that great health and care for our communities is based on great teamwork and everybody working in a fashion which enables not just individual services to do their best, but the total to add up to just more of some of the component parts. And I think that the various aspects of the work we've done, the NRF, I know you're very closely involved in, is a great example, just demonstrates that. So I think we've all got a responsibility as we move into the next phase to continue to work in this highly integrated fashion. It makes perfect sense, and I think better care and services for the people of Lincolnshire.
Thanks, John. I think, Jason, I would probably say that for me, I think John makes the point around the clinical side of things, that yes, they've got a lot of catching up to do there. Where I see a lot of learning from COVID, or a valuable learning that we want to hang on to, and it's a point that Councillor Nanstad touched on earlier, when you look at the voluntary, the community side of things, and the way that all over the county people have sprung up literally in hours to help in their community. We don't want to lose that. We don't want to lose that source of not necessarily information, but certainly that opportunity to know we can plug in support for various areas. And so certainly with the County Council, we're doing a bit through the links to support software that lets, first and foremost, hopefully we get people to help themselves, but equally we've got one place for the whole of the county that you can dip into to get the information you need, or indeed perhaps a social prescriber can look at what people in an area, or a GP. It doesn't matter whether you want the help or you want to give the help. We need for me is a huge learning point, that we've got that through the LRF, and we do need to make use of it. Okay, any other questions at all for John? Can't see any, John, so let's move to the action required. The Health and Wellbeing Board is asked to, as per page 66, note the content of the report, comment on the progress being made in Lincolnshire, and can I ask that the proposed actions are agreed? Does one not agree? If you would like to put your, if you do disagree, wish to abstain, put in the chat function. I can't see anything, Alison, can you?
No, I can't.
Okay, thank you for that. Let's move on to item 7D, which is the Suicide Prevention Strategy and Action Plan. Now, I understand that it is just you, Cqc, Dr. Cqc, the public health consultant who's coming. Shabana is not here any longer, is that correct?
Yes, that's right, Councillor Woolley, and thank you.
In that case, it's over to you. Thanks very much.
This action plan is a one-year action plan and covers the period between October 2020 and September 2021. And the progress update covers the period from October 2020 to the end of January 2021. I'm going to take the report as read and only draw out key points. The action plan was produced in a partnership with all statutory and non-statutory organisations involved in preventing suicides in Lincolnshire. On 8th of January, an engagement session was held with people with lived experience to obtain feedback around supporting males on mental health and suicide prevention. This feedback was used to feed into the Community Suicide Prevention Innovation Fund market engagement event on 12th of January 2021. Following this event, small community groups were invited to apply for bids from the Innovation Fund, and we have received quite a number of bids. We are currently evaluating them, and the successful bidders will be informed shortly. I would like to draw the attention of you to the two actions which are read in the action plan at the moment. One is on development of pathways to support for both individuals and professionals to use. And the second one is to develop the real-time surveillance data. Unfortunately, both of these actions have suffered from redeployment of staff for COVID response, particularly public health staff. So the first one on the pathway development, the end date, the completion date for this has been adjusted to May 2021. And the real-time surveillance, we are thinking of outsourcing it for a short time because we know that our staff will still be involved in the pandemic response for the incoming few months. The one action which is yellow is on exploring alternative data sources to gather intelligence to aid prevention of suicides. This has also suffered from redeployment of staff, not only from public health intelligence team, but from intelligence teams across the system. So we are exploring other options for that delivery of that. I will pause here, and any questions, I'm happy to take them if there are any.
Thank you, Kikuli. Jason.
Certainly, in terms of the communities in Lincolnshire, and certainly from the force, this is a really important piece of work because unfortunately we see on a daily basis, and I know we'll talk about mental health very shortly, the consequences of individuals that ultimately take their own lives. I suppose the first question again is, in terms of our current position, is it getting any worse, or is it roughly the same amount of people that we're losing due to suicide, or do we know that? And the second part for me is, again, I fully agree in terms of other data sources. One of the real challenges around here is the near misses, isn't it? It's the ones that potentially have tried but may not have been successful in trying to take their own life. It's about how confident we are in terms of being able to get that relevant data, because whilst accepting this should be an intervention for those individuals, sometimes we do miss those individuals because we're not joined up as a system in terms of the response to their needs in crisis. So is the situation getting any worse? And again, in terms of the near misses, not so much the ones that have unfortunately taken their own lives, the ones that may have attempted to, are we confident that's one of the data sources that we can get and we can join up as a system?
Shall I take that question?
Oh yes, please, Kikuli, if you would. Thank you.
Thank you, Jason. Yes, in terms of number of suicides, we haven't seen an increase in the number of suicides. Per year, we get about 60 to 80 suicides every year. In terms of data sources, it is difficult to get the data on the near misses because by definition, suicides are those which are completed suicides. We get data from coroner's data after they have completed the inquests. We also get some real-time surveillance data from Lincolnshire Police and British Transport Police.
The near misses are probably the most difficult ones, and probably Sarah will be able to answer that question better because they will be more likely to be in contact with those people. But again, we know that for completed suicides, at least 2/3 of them have never accessed any mental health services, because people commit suicides for various different reasons, and not everyone will have a mental illness prior to their suicides. They may commit suicide because of economic loss, or because of loneliness, social isolation, and recent bereavement of close family members, previous history of self-harm, substance misuse, alcohol misuse, domestic abuse, and all of those people may not be in contact with mental health services or any health services.
Thank you, Kakuli. Derek, did you want to offer some information?
Yeah, there's a couple of things really. I think what Jason's flagged up is really important. It was one of the core planks of work that we did want to do, both with the coroner's office, and we've got really good links in terms of real-time data and surveillance, but notwithstanding capacity with COVID response, we will pick that back up. So really important that we do that. Really important that we link in through our police colleagues, and we'll do that through the approach that we've already got. But I'm sure Sarah will cover it. We need to look at the whole range of mental health and well-being, and look at it in a whole system approach really. I think the final thing, which we'll pick up later, I'm not suggesting to pick it up here because this is an annual, as Kathleen said, it's an annual update on the action plan that the board have already seen previously. I think it's really important though that we think about the language here, and just to flag up, my preferred use is death by suicide, and we should talk about death by suicide rather than anything else, because it destigmatizes clearly people who sadly do lose their life through this route. It's hugely traumatic for the family, and so death by suicide, I think, is the right language. It's the language that's supported by the implementation group, and I think we should recognise that and make sure we're using the same language right the way through.
Thank you, Derek. Yes, I wholeheartedly agree with you there. Are there any other questions from anyone? Okay, we will go to the actions required, and that is on, as far as page 69 is concerned, that we note and discuss the contents of the report and the appendix, and we continue to support the work of the Public Health Division in leading on for suicide prevention. Can I ask that you all agree those actions? And again, if you don't agree, just put in the chat function abstain or against. Okay, that is carried. Can we now move on to item 7E, which is reforming the Mental Health Act White Paper? I'd like to invite and welcome Sarah. We have recently met, haven't we, Sarah? But this is your first Health and Wellbeing Board meeting. Sarah Connery is the Acting Chief Executive of Lincolnshire Partnership NHS Foundation Trust, and she's here to present the report, which provides the board with a summary of the Reforming the Mental Health Act White Paper and the details of the consultation questions. So, Sarah, I understand, I don't know whether it's here or whether it's in the next bit, that Lorraine Graves is going to perhaps be joining you as well from our side, as it were. So, Lorraine, we'll let the both of you fire away. Thanks very much indeed.
Thank you, and thank you for having me here as a guest to present this important piece of proposed change to legislation. So, if I just present the paper, and then perhaps Lorraine, if you want to come in and share thoughts. So, just as a bit of a background, this is quite overdue in terms of a review of the Mental Health Act legislation, and this isn't just about tweaks to the legislation. This is a fundamental change in approach in terms of the guiding principles to the legislation. So the Department of Health and Social Care issued a white paper on the 13th of January. The main proposals, it's in response to recommendations from an earlier independent review of the Mental Health Act. So quite interesting timing in terms of us being in a pandemic, but wanting to put together a really robust response to this. So the new guiding principles, in short, there's a lot of detail in there and the associated papers, but in summary, this is about ensuring service users have choice and autonomy, and that their choices are respected in advance as much as possible in terms of their care and treatment plans. It's also about the least restriction in terms of using the least restrictive way and strengthening and clarifying the criteria used in detention. It's also about therapeutic benefit and making sure that patients are supported to get better and be discharged as quickly as possible. It's also about treating the person as an individual, so ensuring patients are viewed as individuals with enhanced rights to advocacy where required, and also that the access and experience of outcomes for people from BAME backgrounds are adequately addressed as well. So that's the key underlying principles. There's a lot of detail in there, and I have included in Appendix 2 the actual questions that underpin that. It's quite detailed in terms of sections and analyses, but I think overall in terms of the response, what we wanted to do as a system was make sure that we're all on the same page. Generally, we may have different comments, but whether we agree and disagree as a system, as we should be doing things going forward, because when we are treating mental health patients, we've got LPFT that are involved, we've got the AMP services as part of the local authority, we've got the police, often involved in conveyance, for example. So we really wanted to make sure that we all had a chance to make sure that we could respond as a system. Also in terms of that response, so LPFT, the council and the CCG as well, the local commissioning group, have come together and led on that, trying to pull as many responses together as possible. So we've had engagement from East Midlands Ambulance Service, Lincolnshire Police, Primary Care, Third Sector and Voluntary, and also wider community services. We've also tried to engage service users and carers as well in terms of a really strong voice in making sure that we've got their views represented. So in summary, Appendix 3, again, it's quite detailed, but in terms of those principles, there isn't really anything that we would disagree with in terms of the thrust and the change of approach. However, the responses are with caution, because in terms of the changes, there will be resource impacts. There has been an impact analysis undertaken by the department, which comes up with a potential impact of £441 million per year in worst case scenario terms, in terms of and it's not clear where that resource is coming. I know colleagues from the police, for example, there's some concerns there about if there is additional conveyancing required, what that will mean in terms of resources. There's also an important point to make about striking a balance between individual preferences, but also with safety for self and with the public as well. When people are presenting with acute mental illness, there may be an instance where there is a clash between those requirements. So it's just making sure that we proceed with caution around those balances. But overall, it can be shown in Appendix 3 that the system is in general agreement with it, with some caution. But just to say, in terms of timing, it's been quite a tight turnaround in terms of getting the paper to the board today. So we are still getting in elements of feedback. We've had some really rich narrative from Lincolnshire Police, so thank you to colleagues for that, and also from the Shine network as well. So I'll stop there, and I don't know whether Lorraine wants to add anything, and thank you to Lorraine for her support with this really important piece of work.
Lorraine.
Sorry, my microphone didn't want to come on then for some reason. Yeah, totally agree with Sarah. I think it's been a good piece of work and a really fast turnaround, and people have been really engaged with giving, really positive feedback around the proposals that are being made. We have, as Sarah said, Shine Network have done some focused engagement with service users by experience that have actually been through the section process, etc. So it's really good to see some feedback from them that we can feed into this as well. On the whole, I think, you know, it's been a really good system endeavour, and we've reached, you know, a consensus really across the board.
Thank you, Lorraine, and thank you to Sarah as well. There are some questions. So, Jason.
Thanks again, Chair. So Sarah and Lorraine, look, for me, and again, I think you've had this in our feedback, this is, again, it's a really important opportunity, isn't it? The reality is this has a significant opportunity to improve the lives of many people, including family and friends of those that unfortunately find themselves in crisis and need support. I'm very supportive of it. I think, again, I've got some detailed feedback from myself, Sarah. I know there's some more coming to you to make sure it's done, but the important bit is about the whole system. This is the real bit which makes the real change around information, the way we actually deal with individuals with dignity and some respect, and ultimately give them choices. We have got to be conscious about unintended consequences. There is some potential in the short term. We need to work that through. And one of the things I'd certainly ask is, as we put the submission in, it's about our thinking, because the reality is these are likely to change. There might be some tweaking in terms of what's going to change, but they're likely to change. And in terms of our approach now, what can we do now in preparation for, instead of waiting for decision and then doing it? Which then will address some of the potential risks and unintended consequences as well. So certainly very supportive from the police side of it. Really keen to make sure it's a whole system response to it. But again, we just need to work out some potential challenges at the start. And you talked about conveyancing as one of those, Sarah, really.
Thank you, Jason.
Thank you for that, Jason. Are there any other speakers or questions?
Councillor Woolley. Okay, Wendy wants to come in, please, if I may.
Yes, please.
Yes, thank you. Well, all I can say is this is about time that it's come. Having a close member who was sectioned a few years ago, I think it's the most horrific thing that anybody who hasn't had dealings with mental health can ever go through in their lives. I think it's worse than someone dying is the word I would put. A few months ago, I saw that the wards itself were being made from dormitories into rooms, and that in one respect, you know, from I'd say a normal person, because I consider my family member to be normal. He's not normal by any means, but he's a family member. So, you know, that to him was something that was really scary in there. What worries me is that have the doctors, the local GPs, come on board with this? Because him being in the community now, he has real problems with when his medication needs changing. Because still, I know there's a lot of work going in the community. I'm not knocking this by any means. Please don't get that, because it's, you know, this is what we want as a family. We want to know there's somebody in the community before he gets really bad. You know, we want to know there's help there for the family, not just him. It is all that support and that round support, really. And if it gets to the thing that it has to be sectioned again, you know, we want to know who we can speak to. The GPs are not sometimes very understanding. It's that thing that oh well, we know what we're doing, but they don't know what they're doing. With, as we all know, with mental illness and mental illness drugs, they are a very defined thing. So I just wondered if the GPs are on board with this.
Do you want me to come up on? I can pick that up if you like. Yeah. So we have engaged with primary care colleagues in responses. Certainly at the primary care network level, as well as individual GP practices as well. I have to say we've pushed more for engagement, but the timing of it, in terms of everyone's really busy with vaccination rollout, it's not great. And I think you know, ideally we'd have had more months in terms of running up to this. But I think in terms of the general direction of travel, in terms of those principles, they're absolutely in line with what we want in terms of personalised care. You know, least restriction, choice and autonomy. But I have got another meeting on Friday as part of our Provider Alliance, where I'm just going to give it one last push, just to make sure that we've had chance for that proper engagement. Thank you.
Could I just come back quickly, just a little point? Would it not, I mean, in this person's case, he would love to be able to go to a community place where they understand. Would it, and I know it's costly, and I understand all that, but like where he would go to see his psychiatrist, for instance, it would be much easier if there was like a small dispensary or a clinic, I don't know, a nurse that you could go to just for that and not your GP. And I know it's cost, I understand that, but it's sometimes it is the non-understanding. And if there was somewhere, even attached to the hospital, if there was something where you could just go, right, my bloods need doing, I've got my bloods, medication's not right, let's get it changed. I don't know if it's possible.
No, absolutely. If we could maybe pick that up outside of this meeting and have a discussion. I have got a presentation coming up next, but I'd like to think it's maybe the start of maybe some more discussions around particular areas of concern in the system. So maybe if we could pick that discussion up afterwards, I'll be really happy to explore what that option might be. Thank you.
Thanks, Sarah.
Thank you for that offer, Sarah. That's great. Glenn, you have a question.
Not so much a question, Chair, but a nudge for you. Something that both Sarah and I have picked up is that as much as Lincolnshire is trying to think system and provide a collective response to this particular white paper, it would appear that the government hasn't thought of that possibility. And you can only make a submission by way of response to the consultation as an individual organisation. And it just might be useful, Chair, in your role, to sort of make the point to the department that they might like us to think more collectively in the future.
Thank you for that, Glenn. Yes, there was me boasting like hell the other day at a national LGA meeting of how good we are in Lincolnshire, that we're not all sitting in our silos, putting in individual responses. We're going to do a system. And everybody was going, wow, that's good. Wow, blimey, you're all grown up. Yes, leave that one with me, Glenn. Alison, could you just make a bit of a note there? We'll fire something rude off. That's daft, isn't it? Whatever. Right, thank you, Glenn. Okay, shall we now, sorry, I'm just trying to see if there are any other speakers. I don't think there are. So can we move to the actions that are required as per page 91, that we note the contents of the briefing note and consultation questions in the attached appendices 1 and 2, that we note and approve the proposed system response to the consultation in appendix 3, and it will be a system response. And thirdly, that we consider that if there's any feedback on the consultations, that it wish to be included in the final submission. Can I ask, do we all agree those? Again, if you don't, put either abstain or against in the chat. Otherwise, I will take it that we are speaking with one voice and we are agreeing. Thank you very much indeed. Thank you, Sarah. Thank you, Lorraine.
Thank you.
We now move on to item 7F, which is the mental health services in Lincolnshire. And Sarah has very kindly come along to give us a presentation on exactly where we are in Lincolnshire. For those of you, the presentation is on pages 107 to 116 in the pack. Thank you.
Thank you very much. I believe Alison's able to assist in terms of turning over slides. So can we go to the first slide, please, Alison? Thank you very much. So hello again. I am here as the Acting Chief Executive of LPFT, Lincolnshire Partnership NHS Foundation Trust, but the theme of the presentation will definitely be about system working. So I do just want to set a bit of a scene in terms of what we do in LPFT, but also potentially what we don't do as well, further to some of the earlier conversations about suicide prevention. So if you just go to the second slide, please. Thank you. So in terms of the people we serve, just for a bit of context, we don't just provide services in Lincolnshire, we also provide services in North East Lincolnshire. So we provide children and young people's services up in the North East. So we are serving over a sort of 1 million population. And as you might expect with a very rural county like Lincolnshire, we have a number of sites. So we operate from over 50 sites, both community and in hospital. Next slide, please. So just for a bit of context in terms of the size of the organisation, to give it just a bit of a feel for the shape. So an average on a year, we have sort of 360,000 appointments, 50,000 service users on our clinical system. We have 2,500 staff. It's also just worth pointing out as well that we are a foundation trust, which means that we're a membership organisation. I'm proud that we've got over 10,000 members on our register. We also have a really active council of governors as well, with a mix of staff, local representation, education, service user and carer voices, sort of directing the strategy of the trust. They also have particular sort of powers in terms of appointing chair and appointing NEDs as well. In terms of our CQC rating, we're rated safe, good, effective good, caring good, responsive good, and overall sort of well led for outstanding. I just want to point out that the safe services in terms of good, it is quite rare for a mental health trust to have good for all services. So that is something that we're particularly proud of. Next slide, please. Now, I'm not going to go through all of our services in detail, but I suppose it goes without saying that we do provide secondary mental health care from cradle to grave. We have 4 divisions and 2 of them are there in terms of we have an inpatient division and we have a community division. The point I really want to make is that over the past few years, certainly since I've been in Lincolnshire system, that we've worked really closely, regardless of what's happening with ICS legislation, we've worked really closely with commissioning partners. And I don't just mean the CCG, I mean the local authority and also police colleagues as well, in terms of making sure the Lincolnshire pound is spent in Lincolnshire. So we have reduced out of area activity to increase spend and beds in the Lincolnshire system, particularly for psychiatric intensive care. And obviously we want people to be treated as close to home as possible, so having a real positive impact on quality as well. So you can see there that we've had a mental health worker in the police call centre. It just goes to show, I think, in Lincolnshire that we're willing to invest to save, but invest to improve quality and invest to make our system partners' lives easier so that we can be more responsive and provide better effective care. I also just want to point out as well that in LPFT, we lead on the regional veterans mental health care services. So this is obviously really important in terms of the military organisations that we've got in the county as well. We also provide adult social care as well, so we're not just mental health from that point of view. And we've worked really closely with our local authority colleagues in terms of looking what the future might be in terms of integrated health and care. Next slide, please. So in terms of us, so these are the next 2 divisions. So we've got specialist and we've got older people and frailty. Again, it's not just mental health in terms of, we also provide a sexual assault referral centre. We work really closely with our police colleagues in terms of providing an excellent service for those who have had, unfortunately, suffered from a sexual assault. I just want to point out that recently there has been a lot of investment in terms of children and young people services in schools. But our local authority colleagues were ahead of the game in this and invested a significant amount of money in Healthy Minds Lincolnshire. They saw this as a gap in terms of treatment provision a number of years ago. So we've been able to, from the start, build some really strong services there. We've also been quite innovative in terms of our vision for the trust is treating people in the community. So we've taken decisions to close units and move and put the money and invest it instead in community provision, which has been really successful, particularly for what we call Tier 4, which is specialist services for children and adolescents. We had the Ashville unit, we've temporarily closed it, but we've been able to test pilots out in terms of increasing investment in crisis services. So for Lincolnshire, we're actually bucking the trend. So other counties are seeing massive increases in inpatient care for children and young people, and we're not actually seeing that for the population of Lincolnshire, which is really positive. In terms of physical healthcare psychology, we talked earlier, John talked about post-COVID or long COVID. So we're working with community services and our acute colleagues and primary care colleagues in terms of what that service provision will look like going forward, and make sure it's ably invested in to deal with that increasing requirement for the service. Next slide, please. I won't dwell on this slide, but it's just to say our vision and values are really important to us. And I think at the minute, in terms of our recovery planning through COVID, innovation and collaboration are absolutely at the fore. We've really embraced a sort of digital first, not digital only approach. And we've collaborated really closely with colleagues in terms of the vaccination programme. And where we've had to make difficult decisions, we've made sure that we've engaged well with colleagues as well, commissioning colleagues. Next slide, please. So I just wanted to spend a little time, if I may, just talking about our COVID response. So we have had reduced capacity, as all healthcare services have, as people have been isolated while they've been waiting for tests, or indeed been ill with COVID themselves. And we've really had to innovate to deal with the demand. All services have stayed open. In the first lockdown, we did see quite a dip in referrals, but they're pretty much back now to pre-COVID levels. Safety has been our priority, so we have had to take beds out of the system. So people may not be aware, but we've had to lose 8 acute beds and 2 psychiatric intensive care beds. As Councillor Barkett said, we've got dormitory wards, so in terms of maintaining social distancing on those wards, we have had to take out capacity. As I said, we operated a digital first, not digital only approach, and we're looking now in terms of recovery planning with the University of Lincoln in terms of how that might impact on quality and how it feels as a service user to be on the end of a digital consultation as opposed to face-to-face. Importantly, I just want to say, and we touched on it in terms of the suicide prevention action plan, that this isn't necessarily about people having mental illness. This is about, through COVID and beyond, people will feel social isolation, depression and a loss of hope. And that's why we've put in the 24/7 mental health helpline, where sometimes people just might need somebody to talk to. Their social connections aren't there anymore because of lockdown. And we've put in the same for children and young people as well. But what happens is there's a tiered approach. So if there is a risk of that person from that initial assessment needing potential more acute intervention from our services, then it gets escalated up to a tier 2. But it's been immensely successful. I'm more than happy to come back and talk about what kind of levels of activity that we've had through that, but we're absolutely intending to keep that going forward into the future. Next slide, please. An important part of our response as well has been supporting the rest of the system. So we've put on an emotional wellbeing helpline, and this has been to all health and care staff, not just NHS staff. You can see there, it's a bit death by logo, but we didn't want it to feel just like people, it's for NHS staff. So care staff as well and volunteers will be able to access some of these things on offer. We also had priority access to psychological therapies for Lincolnshire health and care staff, and they could self-refer for that. We've also put in a mental health advice line as well to professionals, where if people were having an intervention, so even just in the third sector or voluntary sector, that they could call somebody at LPFT to say, I've got a bit of a concern about this person, what do you think I should do? And that's been really appreciated. Next slide, please. So in terms of a horizon scan, we discussed it earlier. What we're doing at the minute is looking at what that increased demand driven by COVID will be. I have to say it has been a bit of a moving feast, because in terms of the demand models, they're driven by infection rates, lockdown. And as we know, one of the main drivers for mental illness is, the social determinants of ill health. So what's coming next in terms of austerity and potentially continued financial recession. So we're working through what that might mean from a capacity point of view. And as Derek mentioned earlier, the Department of Health and Social Care are coming up with a model, working in line with Public Health England colleagues as well. But myself and Derek are keen that our teams work closely together in terms of having a good grip on what that means from an acuity point of view. In terms of dealing with some of that increased demand, we've been successful in getting some extra money into Lincolnshire for community transformation, working really closely with local authority, with CCG, with third sector, and importantly with service users in terms of what gaps do we need to fill in the services. And a lot of the feedback that we had was around, we don't want to have that no wrong door. Access can be difficult, so what can we do to break down the barriers? And there's a link there. If you click it, there's a short video which kind of summarises what our ambitions are for community mental health. The key point about this is upskilling our citizens and carers and other professions, and doing a bit of demystifying of mental health and really pushing on the self-care agenda. Not everybody needs to end up in LPFT services. There's a lot that we can do through digital means and self-care, hooking up with primary care, hooking up with social prescribers, and just making sure that the pathway is really clear and simple and easy for people to get on and off as and when they need it. We've talked about population health management. I believe there's another paper later on as well. And really exciting. We've been successful in winning £37 million to eradicate those dormitory wards for acute mental health service users, which is just absolutely fantastic, something we've been fighting for years. And so we'll be looking to open those across the next 3 years, 2 wards on the Lincoln County site and 1 at Boston. And a key point for me as I sit here as the Acting Chief Executive is a real focus on patient and carer experience. So we're quite good in the NHS, I think, at counting things, at counting activity, at counting beds, but we're not always so good at understanding how it feels to be on the receiving end of services. I think the Mental Health Act review piece is really important in terms of putting the patient lens, the patient experience lens on that, and the same thing is happening with Cqc ratings as well in terms of making it more about the patient experience. So that's a challenge from us as a trust and as a system to make sure that we're always thinking with that lens in mind. So thank you for listening to me. I'll stop there, and I'm really happy to take any comments or questions. Thank you. You're on mute, Councillor Woolley.
Oh, I was doing so well. Whilst Alison's getting rid of that from our screens, I was going to say thank you very much indeed for that presentation. It's just an update is great. It's really good to know what's going on, and much appreciate you coming. Derek, you have a question.
Well, it's just more of a comment really that Sarah and I and our teams are already in conversation about how we can strengthen this, because as the presentation did a really good job of outlining, there's a huge amount of work and an offer to the people of Lincolnshire already. But one of the bits that we need to strengthen, both coming out of COVID but wider, is that mental wellbeing aspect. And the early emerging plan, which we'll come back to the Health and Wellbeing Board with, is in terms of COVID recovery, probably focusing something around physical activity, because a lot of people have either increased or sometimes decreased their physical activity for a number of reasons, and trying to build on that physical activity as part of COVID recovery, which has obviously physical wellbeing aspect, but also a really strong mental wellbeing aspect. And we've heard that a lot with people connecting with the countryside or the coast because of lockdown. So there's that side. But then the second big area is definitely around mental well-being. And it comes right the way from really positive mental well-being, right the way through, sadly, death through suicide that we talked about earlier, and trying to articulate the whole pathway and what we can do every step of the way to keep people as fit and healthy as possible. We talked about it actually with the Global Burden of Disease Directorate of Public Health Report 2019, if you remember, when we start to look at people who have to live with ill health rather than just look at what people die from. Mental health and well-being and mental ill health and services shoots right the way up the agenda and tends to split cardiovascular disease and cancers as the top 3. And I think a lot of the work that we'll be doing with Sarah and the team over time will help to articulate that in a better way. So it's just it's a positive. It's really good to build on this relationship and the relationship with Sarah, and we'll come back to the Health and Wellbeing Board with those sort of updates as we develop them.
Thanks, Derek. And I think for me, if there's a practical lesson, an observation, the one thing that I have so noticed in my own community is how, well, it feels like rush hour every day with people going out walking, but that wish to want to stop and have a bit of a chat, complete strangers, the number of people that have just, started up a conversation with me, or the other way around, but that wanting to, doing it sensibly and socially distancing. But the point is that you can see the difference it makes on people's faces, and particularly older ones in particular, because generally the young ones have got something in their ears and they can't hear you speaking anyway. But it is quite noticeable. So I'm really pleased that you are going to take that bit further with around the physical activity side of things. Okay, we've got a question from Donald.
It's not so much a question as, well, mainly comment, because I know. Thanks, Sarah, for the report. I agree with what Derek has been saying on this. I mean, there's mental health quite often is seen as a sort of poor relation, in the sense that if someone has a serious physical illness, they get treatment very quickly, invariably do anyway, and people see that, people outside see that they've got a problem, whereas if they've got a mental health problem, other people maybe don't see that, people who see them in the street, because it's not visible. So I do think we need to push this, that mental health is a really serious issue, and Lincolnshire has different communities, but people in very small communities, which can be very isolated, but also people in the city, the towns can also be very isolated because they might not know anybody there, and unless they get some sort of support, what starts off as a fairly low level problem can actually quite quickly deteriorate, and that can lead to all sorts of things, not least of which is pressure on the police services. So I'm pleased that we're looking at COVID in recovery in connection with this, and any chance of getting any more resources from anywhere really needs to happen. The one question I would ask on steps to change, before COVID started, I believe that it wasn't actually straightforward, in the sense you had a delay in having been referred by your GP to this, and you had actually quite a long delay before you actually got anywhere, because you would see one person and go through your issues, then see another person go through your issues before you were then referred on. And for someone, for instance, whose health problems were due to major trauma, they were having to go through their problems each time, which doesn't necessarily help them. But I wondered, how quick now is a refer? If someone gets a GP referral to steps to change, how quickly do they actually get some help, as opposed to someone just assessing them?
Just to say is that you can self-refer to steps to change as well, because I think what we wanted to do was make sure that we're taking out any delay due to having to get an appointment at a GP and then waiting for the referral to come through. In terms of the steps to change weights, it's in line with the national guidance in terms of the 18-week. I think it comes back to my point about the patient experience. So we might be hitting the target, but actually, how does it feel to the person who's waited the longest in terms of those steps to change referrals? But on a positive, we have had additional investment confirmed. It's 2 weeks ago now, in terms of putting extra resource into the steps to change team, because there is national understanding that is one of the areas that is possibly going to get hit. I don't want to say post-COVID, because we're not there yet, but in terms of that demand and capacity modelling, that people are just feeling a little bit in terms of social isolation or loss of hope or depression, and they don't need an inpatient bed on a mental health ward. They just need some, somebody to talk to and to talk through their problems. So there has been additional investment in that area, because it's seen nationally that that's one of the areas. We are hitting the target, but it's back to my point about how does it feel to be sat waiting for something to 18 weeks. It might be in line with the national target, but it still doesn't feel great, does it? Because all the time you might possibly be feeling worse with every week that goes by.
it does seem a long time, 18 weeks. It's not that far off, 6 months.
No.
And for someone who's looking for help and perhaps thinks they're going to get help now, it must be a disappointment, to put it mildly.
It does, but what we do is we do provide a suite of tools for people to use before. So after they've had that first assessment, it's not that they don't have anything. They are given some tools for support to keep them going before their first treatment appointment, if that makes sense. So that they're given, in terms of potential numbers to stay. If they are starting to feel worse, then this is where they should go if they're starting to escalate. But yeah, you know, we try and do as best we can with the resources that we've got. I think in terms of the digital transformation, it's certainly helping in terms of the productivity, because we can, you know, for some people it's actually better to sit at home and have that consultation rather than having to drive into a clinic, for example. So, but yeah, we're learning all the time from that. But I think back to the original point about patient experience being really key.
Oh, thank you.
Thank you. Thank you. Are there any more questions for Sarah at all? Well, on that note, thank you, Sarah. And I would just ask the board to note your presentation, and hopefully you all agree that it's what I was going to say that it's acceptable. There's nobody going to say they're not, but thank you, Sarah.
Thank you.
Hang on a minute. Yes, we've got a well done, Sarah, from Glenn here. So there you go.
Thank you, Glenn.
High praise indeed. Okay, thank you. The next, I think it's 4 items: the implementing a population health management approach, the Better Care Fund, the action log, and the forward plan are all just points of information only items. I don't propose to go through them all unless there is anyone who wishes to comment on a particular item. So I'm going to just go through item 8A. Does anybody want to say anything on the report? No. The Better Care Fund, 8B. Does anybody want to say anything on this report? Item 8C, the action log of previous decisions. And finally, the forward plan. Okay, well, in that case, thank you very much indeed, colleagues. That now concludes the business of the meeting.
So
yes.
Sorry, I just got a delay in getting the mic going. Okay. One thing I just wanted to mention, I was talking to the One New Lincolnshire on Monday, and they are having a bit of an issue getting the buy-ins with the GP surgeries for recommendations. And they could do with a bit of help and support, because there's more that could be done there. And I just said, well, I would raise it here, whether, I don't know how we do that, but it is something that really just wants a bit more pushing. And the reason why is because we were looking locally at more into my area on how we're going to try and get more community buy-in. And of course, one of the GP surgeries, and I won't mention the name, but there was more, and they were struggling a bit with them, and it's like, and it wasn't just there, it was a few others, and I thought I'd raise it.
Thank you, Hugo. I know that Derek will most definitely want to come back to respond on that, so I will let you go first, Derek.
Thank you, Councillor Woolley. Thank you, Councillor Marfley. Yeah, I think it's a function of the fact that with COVID, One New Lincolnshire and obviously a lot of GP practices have operated virtually online and that side of it. And what we're trying to do now is re-engage with primary care to make sure that we're getting the referrals through into One New Lincolnshire. The board will remember that the service specification for One New Lincolnshire is particularly targeted at people with pre-existing conditions, and it's that side of the referral pathway that we want to push really. I completely understand why primary care, it's not at the top of their to-do list, but when we look at what we spoke about earlier around COVID recovery and the fact that what we want to do is focus on physical activity as well as mental well-being, it's an area to re-engage with primary care. I'm sure John and I will pick this up, and we've got plenty of other mechanisms to do so, but it's always worth the Health and Wellbeing Board backing us on this, and I'm sure the vast majority of GP colleagues would also back us on this. It's just about building in some of the COVID recovery and saying there's a lot of services out there already, one of which is co-funded by the County Council and the CCG, and that's One New Lincolnshire. There may also be opportunities to strengthen that depending on what funding streams are available to increase the offer, and that would be great if we can do that. But of course that's subject to the national funding criteria, as I mentioned earlier.
Thank you, Derek. And John, do you want to comment?
Yeah, just to say, Hugo, that if there's one or a small number of GP practices who seem particularly difficult just to get a foot in the door with by comparison to other GP practices, then don't hesitate to drop Derek or I a brief note in relation to that, and we'll see if we can ease it a little bit for the team.
Yeah, brilliant. Thank you.
Thank you both of you for responding to Councillor Murphy. Okay, on that note, colleagues, I will now call the meeting to a close. Thank you for your attendance, and look forward to seeing you sometime soon.